Welcome to the Deep Dive, where your curiosity fuels our exploration. You send us your sources, and we extract the crucial knowledge, delivering it to you in a way that's both efficient and engaging.
Basically, getting straight to the good stuff.
Exactly. Think of it as going straight to the informational gold.
And today, we're diving into the pretty intricate world of endovascular therapeutic techniques.
Yeah, a listener shared chapters from the latest edition of Rutherford's Vascular Surgery and Endovascular Therapy. Big resource.
Oh, definitely. It details how doctors treat blood vessel diseases from the inside out, essentially.
Right. So our mission for this deep dive is to really grasp the core principles, the devices they use, and the key techniques.
The fundamentals of endovascular therapy.
You want to give you a clear understanding of this vital field without, getting totally bogged down in jargon.
Yeah, the source material covers a huge range. I mean, balloon angioplasty, stents, obviously.
But also things like atherectomy devices.
Right, for removing plaque techniques. Techniques for totally blocked arteries. Even how they close up the access points afterwards.
It's a lot, but we're not aiming to turn you into a vascular surgeon overnight here.
No, definitely not.
This is going to be a focused look at the fundamental elements, just giving you a strong base of knowledge. No overwhelm.
Sounds good. So where do we start?
Let's start at the beginning with a technique you've probably heard of, balloon angioplasty.
Yes, PTA, percutaneous transluminal angioplasty. This was really the first big breakthrough, wasn't it? Treating peripheral artery disease without open surgery.
That first percutaneous approach. Daughter and Judkins, 1964.
That's right. They essentially pioneered treating blockages from within the vessel. Catheters, dilation, avoided those big incisions. Revolutionary stuff.
They started with dilators, progressively larger ones, I think.
Yeah, and then later, Grunsig and Kumpe developed the actual balloon catheter, the kind of precursor to what's used now, polyvinyl chloride balloons, flexible.
So when that balloon inflates inside an artery, what's actually happening to the vessel wall?
Okay, so the main mechanism is something called blunt dehiscence. It sounds a bit aggressive, but essentially the balloon's force causes a controlled fracture and separation of the inner layers.
The intima and media?
Exactly. While at the same time, it stretches the outer layers, the media and adventitia. It's basically physically widening that narrowed passage.
Sounds quite forceful, like you said. Are there limitations, downsides to just using a balloon?
Oh, definitely. Especially with really tough, narrowed arteries or ones with lots of calcium, you can get elastic recoil.
Meaning it just springs back?
Pretty much, yeah. Springs back towards its narrowed state once the balloon's deflated. Another risk is flow-limiting dissection.
A tear in the lining.
A tear that actually impedes blood flow. And these issues, recoil and dissection, are exactly why stents are so often used after angioplasty.
Ah, okay. So the balloon opens it up, but the stent acts like a scaffold to keep it open.
Precisely. The balloon does the initial work, the stent provides the lasting support.
But the source also mentions drug-coated balloons, DCBs. How do they fit in? Are they trying to avoid the stent?
That's the idea. DCBs are a really innovative approach. They're designed to deliver medication directly onto the artery wall during that balloon inflation.
What kind of medication?
It's an anti-proliferative drug. The goal is to stop the smooth muscle cells from growing excessively, because that cell growth is a major reason arteries re-narrow after treatment.
So it targets the healing response itself.
Exactly. It's like a very localized, very targeted drug delivery system, aiming to reduce the need for that permanent metal scaffold.
Interesting. Less foreign material left behind. Now, talking about the balloons themselves, it's not just one type fits all, right? The source mentioned different catheter types.
Correct. For peripheral artery disease, we mainly see two types: over-the-wire, or OTW systems, and rapid exchange RX systems, sometimes called monorail.
Okay, OTW first. What defines that system?
With OTW, the guide wire runs through the entire length of the balloon catheter shaft. These shafts can be quite long, maybe 80 to 150 centimeters.
Which means you need a really long wire too, right?
Absolutely. For those longer shafts, you need guide wires of 260 centimeters or even more, just to make sure it extends out the end. The key thing with OTW is it gives you good control, good manipulation, especially in tricky anatomy.
Okay, makes sense. And the RX, or monorail system, how's that different?
It's a distinct design. The guide wire goes into the balloon at the very tip, but then it exits through a little side port, maybe 20-25 centimeters up the shaft.
Not the whole length, then?
Not at all. And these are often used with really fine wires, 0.014, 0.018 inch. They're particularly useful for treating lesions below the knee, where the arteries get much smaller.
And the advantage there?
Well, a key insight is that the RX design allows for quicker balloon exchanges
Yeah.
because the wire isn't running the full length.
Easier to handle.
Yeah, often a single operator can manage inserting, advancing, and swapping balloons while keeping control of that short wire segment. You don't need those super long exchange wires.
So faster procedures, lower profile maybe?
Generally, yes. Streamlined, less time. And RX systems usually do have a lower profile, meaning the deflated balloon is smaller. That can really help navigate very tight narrowings. The core benefit is efficiency, especially in those difficult distal vessels.
But there must be trade-offs, right? Disadvantages to RX.
There are. That lower profile often comes at the cost of pushability and trackability. They might not advance or steer quite as well in very complex or tortuous paths.
Harder to push through resistance.
Potentially. And also, because the wire exits mid-shaft, if you need to exchange the wire itself, it's more complicated. You often need a special transfer catheter or a long sheath to maintain access. So, great in some situations, but maybe not the best for every single case.
Right, got it. Now, the balloons themselves have characteristics like compliance. What does that tell us?
Balloon compliance is basically how much the balloon's diameter expands when you increase the inflation pressure. It's mostly down to the type of plastic polymer they use to make the balloon.
Okay, and it's defined by pressure ratings.
Yes, usually by the range between the nominal pressure, that's the pressure where it reaches its stated size, and the rated burst pressure, or RBP.
The point where it might pop.
Essentially, yeah. The pressure where the risk of rupture goes up significantly. Understanding compliance is really key for picking the right balloon for the specific lesion and vessel.
So we have compliant and non-compliant balloons. What's the difference in how they act and when you'd use them?
Right. Compliant balloons, often made of things like polyolefin copolymer or polyethylene, they're generally more flexible. Great for navigating twisty curved vessels.
Track better.
Exactly. They also tend to dilate more gently, maybe less risk of sudden vessel damage. But a potential downside is the doggy bone effect at higher pressures.
Doggy bone.
Yeah, the ends inflate more than the middle. That could potentially injure the healthy vessel next to the blockage. And they're not ideal for really hard calcified lesions.
But an advantage.
A big one is that a single compliant balloon might work well across a slightly wider range of vessel diameters. More versatile in that sense.
Okay. And the non-compliant ones. High pressure, low compliance.
These are typically made from materials like polyethylene terephthalate, PET, or nylon reinforced polyurethane. They're built for better radial force.
More outward push?
Much more. They hold their shape really well even at high pressures. They have higher RBPs, and they're the go-to for heavily calcified lesions. Also used for post-dilating stents after deployment, making sure they're fully expanded.
Downsides. Less flexible.
Generally less flexible, yes. Might be harder to navigate curves, and they do exert more recoil force on the vessel after deflation. So again, the choice really depends on the blockage and the vessel anatomy.
Makes sense. What about balloon profile? Measured in French sizes. Why does the deflated size matter?
The profile, the cross-sectional diameter when it's deflated, is critical for just getting the balloon to the lesion and across it, especially with very tight narrowings.
Smaller is better for crossing.
Generally, yes. A smaller profile helps navigate tight spots with less resistance. Most peripheral balloons fit through 4 to 6 French sheaths. And interestingly, those newer .014 and .018-inch wire systems tend to have smaller profile balloons compared to the older .035-inch systems. That smaller profile can be a real help.
Okay, smaller gets you through the tight spots. Now the source then moves into some pretty specialized balloons. Cutting balloons first, the name sounds aggressive.
It does, yeah. Cutting balloons are basically standard angioplasty balloons, but they have these tiny surgical blades, like 3 or 4 of them, mounted along the outside. Atherotomes, they're called.
And they actually cut the plaque.
They're designed to create controlled microincisions in the plaque as the balloon inflates. They usually need those smaller .014 or .018-inch wires and a 6 French sheath.
And where would you use these specific situations?
Yeah, they're typically for shorter lesions where that cutting action is beneficial. Think stenosis and vein grafts used for bypass. Lesions at bifurcations, where a vessel splits. Heavily calcified lesions that resist standard balloons. Areas where you really want to avoid a stent, like the common femoral or popliteal artery.
Ah, the no-stent zones.
Exactly. And even for instant restenosis, where scar tissue builds up inside an old stent. They're generally not for long, sprawling blockages. The key is those small cuts help disrupt the plaque, allowing for better dilation with less recoil.
And do they work better than regular balloons in those cases? Is there evidence?
Some studies suggest advantages, yes. There's evidence for better patency rates compared to conventional PTA for short blockages in the SFA and popliteal arteries. They've also shown use in hemodialysis fistulas, and interestingly, helping to fracture calcium when used with rotational atherectomy.
Okay. What about scoring balloons? Sounds a bit gentler than cutting.
Scoring balloons like the angiosculpt or Vascular are designed to focus the dilating pressure more precisely. Angiosculpt has these fine nitinol wires in a spiral pattern on the surface.
And when it inflates.
The wires create longitudinal scores on the plaque. There's one-year data showing pretty good patency in calcified SFA popliteal lesions with this. The idea is the scoring creates stress points, channels, leading to more controlled dilation.
And the Vascular, similar idea.
Similar principle, different design. Vascular uses two thin wires running lengthwise. They estimate these create incredibly high focal pressure, maybe 50 to 400 times more than a standard balloon at the same pressure.
Wow.
Yeah. Evidence is still a bit limited compared to some others, but it's been reported as safe and effective when used to prep the vessel before a drug-coated balloon in SFA pop lesions. Focused pressure to help drug delivery and expansion.
Okay, different ways to apply pressure effectively. Next up, cryoplasty. Sounds cold.
It is. Cryoplasty combines balloon dilation with cold thermal energy. They inflate a special balloon with liquid nitrous oxide, chilling the lesion down to about minus 10 degrees Celsius during dilation.
And the theory behind that?
The theory was that the cold might reduce that problematic cell overgrowth, the myointimal hyperplasia, which causes arteries to re-narrow. Hopes were for better long-term patency without needing a stent.
And did the cold therapy pan out? Did it work?
Unfortunately, not really. Reviews of multiple randomized trials comparing it to standard angioplasty generally haven't shown a significant difference in patency or restenosis rates.
No clear benefit.
Not consistently. There was maybe a slight hint of improvement at 6 months for instant restenosis in the SFA in one analysis, but overall, the evidence for a real clinical benefit is weak. Given that, plus the extra cost, its role seems pretty limited now.
Makes sense. Okay, let's circle back to drug-coated balloons. We touched on them as a stent alternative. Let's get into the details, how they work, the evidence.
Right. So as we said, DCBs deliver anti-proliferative drugs right to the vessel wall during that brief inflation, aiming to stop smooth muscle cell growth, the main culprit in restenosis.
Inspired by drug-eluting stents in the heart.
Exactly. Those coronary DES, like Cypher with sirolimus or Taxxus with paclitaxel, were a big deal for reducing re-narrowing in heart arteries. DCBs try to get that drug effect without the permanent implant.
Yeah, those coronary DES were helpful, but they had their own issues too, didn't they? Didn't always prolong life compared to bypass in some groups.
That's true. Trials like Syntax showed limitations. Plus, patients needed long-term dual antiplatelet therapy, blood thinners, to reduce the risk of clots forming inside the stent, called subacute thrombosis.
So how are the peripheral DCBs designed and used differently?
For peripheral use, especially SFA below the knee, they're typically over-the-wire dual-lumen catheters. Semi-compliant balloon, usually an atraumatic tip so it doesn't damage the vessel. And a key recommendation is a long inflation time.
How long?
Minimum 60 seconds at the target pressure. That's crucial to give the drug enough time to transfer from the balloon coating into the vessel wall tissue.
And the drug is usually paclitaxel.
Paclitaxel is the most common one used in peripheral DCBs, yes. Several big trials looked at these. Levant 1 was a key early European trial.
What did it compare?
It compared the Lutonix DCB, which has a low dose of paclitaxel, against standard uncoated balloons for SFA and popliteal lesions.
And the results?
Significant reduction in late lumen loss, the measure of re-narrowing over time, and higher primary patency rates in the DCB group at 6 and 12 months. So a clear signal of benefit from the drug.
That sounds promising. Did that lead to bigger trials?
Absolutely. Levant 2 was the follow-up. A large, global, prospective, randomized trial. Again, Lutonix DCB versus standard PTA in the SFA popliteal.
Same result. Better patency.
Yes. Superior primary patency for the DCB group at 12 months. Importantly, this trial also found no significant difference in major safety outcomes like death, amputation, or need for re-intervention between the groups.
So better patency, seemingly without a major safety trade-off, at least initially.
That's what these early trials suggested, yeah. And then other major studies like Ranger SFA, Impact SFA, and Illuminate further backed up the idea that paclitaxel-coated balloons were more effective than plain PTA in the SFA.
What about longer term? Did the benefit last?
Good question. Some studies now have data out to 3 years, and generally they show a sustained advantage for DCBs. Higher primary patency, fewer repeat procedures needed compared to PTA, That durability was encouraging.
That all sounds very positive for DCBs, but I seem to recall some controversy, some safety concerns cropping up later.
You're right, there was. In 2018, a meta-analysis by Katsanos and colleagues caused quite a stir. It suggested a potential increased risk of late mortality death, occurring maybe 2 years or more after the procedure in patients treated with paclitaxel-coated balloons in the femoral popliteal arteries.
Increased risk of death. That's serious.
Very serious. The analysis suggested almost a doubling of the relative risk of death from any cause compared to patients who got uncoated balloons. Understandably, this led to a lot of debate and scrutiny.
What was the response? Were there criticisms of that analysis?
There were. The Katsanos meta-analysis was criticized for relying on summary-level data from trials, not individual patient data. This makes it harder to account for potential confounding factors, other differences between the groups. It was difficult to definitively prove a causal link between the paclitaxel and the balloon and late mortality just from that data.
So what happened next? More analysis.
Yes. In response, researchers conducted new meta-analyses using patient-level data, which is much more granular. Analyses of the Illuminate trials out to 3 years, and another big pooled analysis by Schneider and colleagues looking at data out to 5 years, did not find a statistically significant difference in mortality rates between DCB patients and PTA patients.
Okay, so the more detailed data was more reassuring.
Generally, yes. Those later analyses provided a more comforting picture regarding long-term safety.
So is the safety question settled now?
Not entirely. While that patient-level data is good news, the long-term picture, especially for really complex lesions or over very long follow-up times, still needs ongoing study. The exact role of DCBs is still being refined. It really highlights the need for careful patient selection and continued monitoring.
Okay, that gives us a really good handle on balloon angioplasty and its variations, including the promise and the ongoing questions around DCBs. Let's shift gears now to another cornerstone, stents. Interesting origin for the name, apparently, linked to a dentist.
It is the great story. Yeah, the term stent comes from Charles R. Stent, a British dental surgeon. He developed this moldable compound for making dental impressions.
And that somehow led to vascular devices.
Over time, the term just kind of evolved to mean any supportive scaffold used to keep a body passage open. So in vascular medicine, stents are key for reducing that re-narrowing, restenosis, and dealing with acute problems like recoil or dissection right after ballooning. The dentist's legacy lives on.
Amazing connection. When did stents actually start being used in blood vessels?
Well, Charles' daughter, the PTA pioneer we mentioned, actually reported experiments using coil spring grafts in dog popliteal arteries way back in 1964. First documented transluminal metallic stent.
Wow, that early.
Yeah, but the nitinol stents, the nickel titanium alloy ones, that are standard now because they're flexible and have shape memory, they didn't really kick off until the 1980s.
And the first FDA-approved one for peripheral use.
That was developed by Paul Maas and colleagues, a balloon expandable stent approved in 1985. Studies then showed it was better than PTA alone for keeping vessels open. It was a huge step.
A real game changer for durability. Now, the source classifies stents. What are the main categories?
The big classifications are based on how they're deployed. Balloon expandable stents, BES, or self-expanding stents, SES. Then you can classify them by material and design. Bare metal stents versus covered stents, which are also called stent grafts or endografts.
Materials, steel, nitinol.
Bare metal can be stainless steel, nitinol, cobalt, chrome, other alloys. Covered stents add a layer of material like PTFE, polyurethane, or silicone over that metal frame. And all these differences, material, design, deployment, affect things like flexibility, radial strength.
Radial strength being the outward push.
Right, how well it resists being crushed. Also, kink resistance, biocompatibility, all influencing how well it works long term.
Okay, let's unpack balloon expandable stents first.
Yeah.
BES, key features. How do they work?
The Palmas stent was the first commercial one, widely studied. BES are basically slotted metal tubes crimped down onto an angioplasty balloon.
So you inflate the balloon to deploy the stent.
Exactly. Position the balloon, inflate it, the force expands the stent, embedding it into the vessel wall. Sometimes you see that doggy bone shape initially as the ends expand slightly faster before the whole thing opens up. The key is the permanent deformation of the metal providing immediate support.
Advantages and disadvantages of BES in peripheral arteries.
The big advantage is their rigidity once deployed. Great resistance to that elastic recoil we talked about. They also allow for very precise placement, and they tend to show up better on X-ray, more radiopaque than some SES.
But downsides, rigidity can be bad too.
It can. They can be permanently deformed if crushed by external forces. So not ideal for vessels in areas that get squeezed or bent a lot.
Like the leg arteries during movement?
Exactly.
Yeah.
Also, some designs can shorten slightly if overdilated, foreshortening. And most older stainless steel ones create MRI artifacts. Newer cobalt chromium ones are better, more radial force, lower profile, more flexible, fewer MRI issues. So it's a balance. Need for strong support versus the vessel's location and potential for compression.
So where are BES typically the preferred choice? Specific locations?
Often for heavily calcified osteolesions, those narrowings right at the origin where a vessel branches off a bigger one.
Like renal or iliac arteries?
Precisely. Renal, mesenteric, iliac, subclavian, brachiocephalic ostia. Their precise deployment and strong outward push work well there. But, as we said, generally avoided in compressible vessels like the internal carotid or the SFA in the thigh. Could get crushed.
Okay, clear picture on BES. Now, self-expanding stents, SES, how are they different? Mechanism, characteristics.
SES are usually made of nitinol, that nickel-titanium alloy with shape memory and flexibility. Unlike BES, they're designed to be deployed compressed, and then they gradually expand to their preset size once released from the delivery system.
So they spring open on their own?
Essentially, yes. You usually choose one slightly larger than the target vessel, so it exerts a continuous outward force, keeping the vessel open and staying snug against the wall, good apposition. The final size is a balance between the vessel wanting to recoil and the stent pushing out.
And the key advantages of SES?
Flexibility is a major one, much more flexible than most BES. This means better trackability, easier to navigate curvy, tortuous vessels. They're also generally more resistant to fracture from movement or external forces.
Sizing is more forgiving too.
Generally, yeah. And they tend to achieve good vessel wall apposition, maybe less risk of perforation. Plus, nitinol is non-ferromagnetic, so fewer MRI artifacts, which is good for follow-up imaging. Their flexibility is a big plus for certain anatomical challenges.
How are they actually deployed then, if not by balloon inflation?
Deployment varies a bit by manufacturer, but most are preloaded, compressed inside a delivery sheath. You advance it over the wire to the spot, then you gradually pull back the outer sheath.
And the stent opens up as it's uncovered?
Right, it springs open, usually distal end first, moving proximally. A key point. Most SES, once you start deploying them, can't easily be recaptured or repositioned. The wall stent is an exception with its deployment mechanism.
Mostly over-the-wire systems?
Mostly OTW, though there are some rapid exchange like Masago. And designs have evolved modifications for calcified lesions or areas under stress, like the Supra stent with its interwoven nitinol wires, designed for the SFA's demands.
The source also mentions open cell versus closed cell designs in SES. Functional differences.
Yeah, that's about the architecture of the stent mesh. Open cell stents have struts, forming larger, more open spaces. Gives them high flexibility, great for tortuous vessels.
But downsides?
Can be more prone to deformation, maybe less uniform radial force, and potentially plaque could bulge through the bigger openings. Closed cell stents have a tighter mesh, smaller interconnected cells.
Better scaffolding? Less embolization risk?
Potentially less embolization risk. Yeah, the finer mesh might trap debris better. But they tend to be less flexible, might not conform as well to very curvy vessels.
So a trade-off again?
Exactly. And some newer designs try to get the best of both worlds. Open cell body for flexibility, closed cell ends for better scaffolding, and edge support. Stents like Smart, Masago, Epic, LifeStent use this kind of hybrid approach. The choice depends on the anatomy and what you're trying to achieve.
Interesting designs. Okay, let's move to stent grafts. Covered stents? Sounds like a stent plus a graft layer.
That's exactly what they are. A stent frame could be balloon expandable or self-expanding, covered with a synthetic graft material. BTFE is common, polyurethane, silicone.
And the purpose of the covering?
It provides structural support, like any stent, but also creates a barrier, useful for sealing off leaks, aneurysms, or just providing a smoother, maybe more blood-compatible inner surface. We have both BES and SES versions.
Let's start with the balloon expandable covered stents. Examples. Applications.
Examples include iCast, Viabond VVX, though VVX has some self-expanding properties too, LifeStream, Jostent, B-Graft. The iCast is stainless steel covered with PTFE. One feature is you can expand it beyond its stated size, but it might shorten a bit when you do.
Wire and sheath size.
Usually 0.035-inch wire, 6 or 7 French sheath, depending on size. Its main FDA approval is actually for airways, tracheobronchial strictures.
But used off-label in blood vessels.
Frequently. For iliac and renal blockages, vessel perforations, in-stent restenosis, even reconstructing side branches during complex aorta repairs.
Main advantage, disadvantage.
Advantage is often a relatively low delivery profile. Disadvantage is rigidity less suitable for twisty vessels or areas that move a lot. Long-term data for peripheral blockages is still a bit limited, but one ICAST study showed around 75% primary patency at 5 years.
Okay. And self-expanding covered stents, key
Yeah.
devices, rolls.
The main ones are Viabon and its successor VBX Fluency and the Flare endograft. The original Viabon has a heparin-bonded PTFE graft on a single-wire nitinol frame, no longitudinal connections, making it very flexible.
Studied in trials.
Yes, Viper looked at long SFA blockages, showed 73% primary patency at 1 year. Didn't seem to matter how long the lesion was. Viastar compared Viabon to bare metal stents in the SFA. Viabon came out on top for 2-year primary patency, especially for really long lesions, 20 centimeters or more. Similar rates for avoiding bypass or re-intervention, but the pattern of re-narrowing differed. Viabon tended to narrow at the edges, bare metal stents more diffusely inside.
Deployment. Wire size.
Viabon uses a thinner 0.018-inch wire, 6/7 far sheath, deployed with a ripcord. Flare is another nitinol PTFE graft, specifically for hemodialysis graft stenosis, shown to be better than PTA there. Needs a bigger 9 far sheath. Fluency is also nitinol PTA based on the Luminix design, has short bare stent ends. FDA approved for biliary use, but used off-label in vessels. 9FR compatible, 0.03 5 wire. So SES-covered stents are valuable when you need both support and a barrier, like long lesions, perforations, aneurysms.
Right. Specific tools for specific jobs. Now, drug-eluting stents, DES, for peripheral arteries. We talked about drug-coated balloons, no stent left behind. How do peripheral DES compare?
DES were developed to tackle the big limitations of bare metal stents,
Oh.
in-stent restenosis and stent thrombosis, especially in long lesions or multiple stents. The idea is the stent itself slowly releases an anti-proliferative drug into the vessel wall.
Like the coronary DES.
Exactly. Paclitaxel, sirolimus, those drugs significantly cut down restenosis in coronary arteries. But translating that success to peripheral arteries has been more challenging.
Oh, early peripheral DES didn't work as well.
Some early ones, like the sirolimus-eluting SMART stent, studied in Sirocco III, didn't show a significant reduction in restenosis at 2 years compared to bare metal stents in the SFA. Same for the everolimus-eluting Dynalink stent. It seems the biological response might be different in peripheral versus coronary arteries.
Why the difference? More complex disease, mechanical forces.
Likely a combination. Peripheral arteries, especially in the legs, often have tougher, more calcified, longer blockages. And the mechanical stresses, compression, bending, twisting, are way higher than in the heart. That can affect drug uptake, stent integrity, the whole healing process.
But there have been successes more recently. Newer peripheral DES.
Yes, definitely. The Silver PTX stent from Cook Medical has been a significant one. It's polymer-free, elutes paclitaxel directly from the stent surface.
How does it release the drug?
Mostly in the first few days, but detectable levels stay for up to 56 days. A big randomized trial showed it had superior primary patency compared to both PTA alone and PTA, plus a bare metal stent at 1 year in femoral popliteal lesions. And that benefit held up out to 5 years.
That's strong evidence.
It was. And in a secondary part of the trial, Silver PTX also beat bare metal stenting at 12 months. Really established its efficacy.
Are there other successful peripheral DES?
Yes, the Alluvia stent from Boston Scientific is another key one. It does use a polymer coating, but it's designed for a controlled, sustained, low-dose release of paclitaxel for over a year. It's built on their Innova stent platform.
How does it compare to Silver PTX?
The Imperial trial compared them head-to-head in femoral popliteal PAD. Alluvia was found to be non-inferior for primary patency and major adverse events at 12 months. So another effective option in the peripheral DES toolkit.
So DES tech is finding its place in peripheral disease now.
Okay.
Shifting slightly multi-layer flow modulator stents. Sounds specialized.
Very specialized, you're right. MFM stents from Cardiatis are designed specifically for treating peripheral and visceral aneurysms, but with the goal of keeping blood flow to important side branches that might come off the aneurysm.
How do they do that? They're not covered.
No, they're uncovered, self-expanding stents made of cobalt alloy. The key is their structure. Multiple layers, creating a very high porosity, about 65%. This unique design changes the blood flow dynamics within the aneurysm sac.
How does that help?
It encourages thrombus, blood clot, to form and fill the aneurysm sac, essentially sealing it off from within, while the porosity aims to let blood continue flowing through adjacent side branches. It's a flow modulation strategy, not exclusion like a covered stent.
Clever. Has it worked in practice?
It got European approval back in 2009. Early studies, like an Italian multi-center trial, have shown good results. Decent one-year patency of the main artery, very high side branch patency, aneurysm thrombosis in most cases, and no reported ruptures. It's also being looked at for complex aortic dissections and supplementing standard EVR, a really different approach to aneurysms.
Fascinating. Lastly, on stents. Bioabsorbable stents, BVS, the disappearing stent idea is appealing. How's that going in peripheral arteries?
The concept of a scaffold that supports the vessel that dissolves over 2-3 years is incredibly attractive. Theoretical benefits are huge. Restore natural vessel movement, no permanent implant left behind, easier future interventions or bypass.
Started in coronary arteries.
Mostly, yeah. Early ones made of things like polylactic acid.
And in the legs, peripheral arteries. How's the experience been?
Less encouraging so far, unfortunately. The GIIA study looked at an early coronary BVS, igaki in femoropopliteal lesions. High technical success putting them in, but really high restenosis rates at 6 and 12 months.
What went wrong?
Looking at the re-narrowed tissue showed a mix of things. Typical scar tissue growth, leftover stent material, inflammation, clot, and other registry data comparing that BVS to modern nitinol SES and the SFA also showed lower patency with the bioabsorbable one.
So still a work in progress for peripheral.
Very much so. It's unclear if or when the technology will get to the point where it can reliably replace durable metallic stents for PAD. The long-term potential is there, but current peripheral BVS haven't matched the performance of existing metal stents yet.
Okay, that's a great tour of the stent landscape. Let's pivot now to another important tool set, atherectomy devices. These actually remove plaque, right? When are they used?
Exactly. Atherectomy physically removes atherosclerotic plaque. It's useful in a few key scenarios. One is debulking really heavy, calcified, or fibrotic lesions before angioplasty or stenting. The idea is to make those subsequent steps work better.
Better immediate result, maybe longer lasting.
That's the hope. Another major use is in those no-stent zones we talked about, common femoral popliteal artery near the knee, where you really want to avoid leaving a stent if possible because of the high risk of fracture. Removing plaque instead of just squashing it might improve flow enough without needing a stent there.
Makes sense. The source outlines 4 main types: directional, rotational, orbital, and laser. Let's start with directional. How does that work?
Directional atherectomy systems like Silverhawk and Turbohawk use a small, sharp carbide cutting blade inside the catheter. It rotates at high speed, up to 8,000 RPM, to literally shave off the plaque.
And where does the shaved off plaque go?
Good question. The catheter has a collection chamber, a nose cone, and a plunger system to basically suck up and remove the debris, the atherema, from the body. Turbohawk is beefed up for tougher calcium.
Delivery system, standalone treatment.
Usually monorail catheter, 0.014-inch wire, 6/8 French sheath. And yes, sometimes, especially with softer plaque, it can be used alone without needing balloons or stents afterwards. Studies like Definitive Cap++ showed good technical success and low complications in calcified fempop lesions when used with embolic protection. Definitive L showed decent patency and low amputation rates in critical limb ischemia patients.
Okay. Next is rotational atherectomy. Sounds like high-speed grinding.
That's a good way to think of it. It uses a high-speed rotating burr coated with tiny diamond microchips. Spins incredibly fast, 150,000 to 200,000 RPM. It abrades or pulverizes hard calcified plaque into microscopic particles. Tiny enough, mostly smaller than red blood cells, to pass safely through the circulation downstream.
Does it damage the healthy vessel wall?
The principle is differential cutting. It preferentially tackles the hard, inelastic calcium, but tends to deflect off the softer, elastic normal wall. Great for prepping really calcified lesions before balloons or stents.
Evidence for it.
The Pathway PVD study in the SFA showed high success rates, low adverse events, though reintervention rates are around 26% at a year. It's also been tried for instant restenosis with mixed results. A hybrid approach, rotational atherectomy than a drug-coated balloon, showed some promise for blocked stents. The JG registry tracked real-world use, too.
Then there's orbital atherectomy. How's that different from rotational?
Orbital, like the Diamondback 360-degree system, also uses high-speed rotation, but instead of a fixed burr, it has an eccentrically mounted diamond-coated crown. As it spins, it orbits around the guide wire,
Creating a wider path.
Exactly. The orbital motion makes a slightly larger effective cutting diameter than the crown itself. It also allows for differential cutting based on how compliant the vessel is. Uses a small 4/4 sheath, standard 0.014 wire. Like rotational, it creates very fine debris, thought to minimize embolization risk.
Effective.
The confirmed study showed it works well for calcified lower extremity lesions, significantly reducing plaque burden. Office-based studies also reported good patency rates at midterm follow-up.
And finally, laser atherectomy. What kind of laser? How does it work?
Typically an excimer laser, specific ultraviolet wavelength, 308 nanometers. It ablates plaque and thrombus through photochemical ablation, basically vaporizes on direct contact. Supposedly minimal thermal damage to surrounding tissue.
Clinical results.
A study in critical limb ischemia showed high success rates, restored flow to the foot, good patency, and limb salvage out to 2 years. For instant restenosis, one trial found laser plus PTA was better than PTA alone. Fewer reinterventions at 6 months, lower adverse events. A systematic review also suggested adjuvant laser might be better than standard angioplasty for ISR. Trials are ongoing to figure out its optimal role.
So quite a toolkit for plaque removal, each with its niche. Let's switch to removing blood clots now, thromboembolectomy.
Right. Removing thrombus, blood clots, from arteries or veins. We have the classic Fogarty catheter for open surgery, but now many percutaneous techniques too. Coronary, peripheral arteries, DVT, even pulmonary and cerebral vessels.
You can use clot-busting drugs, thrombolysis, but that has risks.
Exactly. Catheter-directed thrombolysis works but carries risks of bleeding, clot fragments breaking off and traveling downstream, embolization, and the clot coming back. So mechanical thrombectomy devices were developed to try and reduce those risks and remove clot more efficiently.
The source mentions aspiration thrombectomy first. Sounds simple, just suctioning the clot.
It is relatively straightforward. Use a large bore catheter or sheath to directly aspirate the thrombus. Lots of devices available: Priority 1, Aspire, Export, Pronto, etc.
Downsides?
Risk of distal embolization if the clot breaks up during suctioning. Sometimes thrombolytics are used locally through the catheter to help. Works best in smaller vessels, maybe less than 6 millimeter. Less effective for really big old organized clots. One study showed 64% success with aspiration alone in limb ischemia, but 96% when combined with angioplast stent picking, often used as part of a combined approach.
What about rheolytic thrombectomy? Sounds like it uses fluid jets.
It does. Rheolytic devices like the angiojet catheter shoot high-velocity saline jets backward from the tip. This creates a low-pressure zone, the Venturi effect, which helps dissolve and suck the thrombus into the catheter.
Actively breaks it down.
Yes. The vortex draws clot in, the jets fragment it, and it's aspirated out. The Pearl Registry for Acute Limb Ischemia showed high procedural success and good outcomes at 1 year with angiojet. Also used for DVT, the Burn Venous Stent Registry showed high success for iliofemoral DVT. The advantage is actively removing clot, potentially needing less catalytic drug infusion.
And rotational thrombectomy, similar to rotational atherectomy, but for clot.
Pretty much. Uses a mechanically rotating element to macerate and remove thrombus. The Rotaract system has a rotating tip, maybe 40,000 RPM. It's been studied for peripheral arterial clots, high technical success, though 6-month patency was around 65% in one study, amputation about 12%.
Other devices, hybrid approaches.
Yeah, the trellis catheter combines locolytics with mechanical disruption and aspiration using balloons to isolate the clot segment. Show good results in acute limb ischemia. For DVT, rotational systems like the cleaner have shown good technical success in patency.
And interestingly, the source mentions stent retrievers, like for stroke, being used peripherally.
Absolutely. Devices like Solitaire and Trevo, designed for removing clots in the brain during stroke, are being used off-label in peripheral arteries, especially for tricky acute limb ischemia when aspiration fails, or for clots in small below-the-knee arteries.
How do they work again?
They have a self-expanding stent-like mesh. You deploy it across the clot gets tangled in the mesh, then you pull the whole thing back into a guiding catheter and remove it. The Indigo system from Penumbra is another aspiration system used for peripheral clots, including visceral and upper extremity arteries. It shows how technologies cross over between vascular beds.
Fascinating crossover. Now, a specific challenge. Crossing chronic total occlusions, CTOs, those completely blocked arteries. What specialized tools are there?
CTOs are tough,
Yeah.
often long-standing dense calcified blockages. You need specialized wires and catheters. The goal is either to get through the original true lumen or go subintimal into the vessel wall layer and then re-enter the true lumen further down.
Devices for true lumen crossing.
Things like the crosser catheter, Frontrunner XP, they often have stiff, tapered tips, maybe some microdissection capability. Success rates reported around 83–88%, with low complications and experienced hands.
And for subintimal crossing with re-entry.
Devices like Outback LTD, Pioneer, and Tier Off-Road, they have steerable tips and features to help punch back into the true lumen distal to the blockage. Similar success and low complication rates reported. One potential risk with some reentry devices like Outback is extending the dissection plane significantly. The choice depends heavily on the CTO's characteristics length, calcium, side branches.
Very intricate work. Okay, so after all these procedures, balloons, stents, atherectomy, thrombectomy, you need to close the hole in the artery where you went in. Access site closure, critical final step.
Absolutely crucial. Access site complications, bleeding, hematomas, pseudoaneurysms are a major cause of problems after these procedures. Manual compression, just holding pressure, is the traditional way.
But it takes time, doesn't always work.
Exactly. Time-consuming, uncomfortable can fail, especially with the larger sheaths used for complex stuff like EVAR or TAVR. So various vascular closure devices, VCDs, were developed. Aim is faster, secure closure without complications like infection or thrombosis.
Are VCDs proven better or safer than manual compression?
Large trials, like ISAR closure in coronary patients and meta-analyses, generally show comparable rates of major vascular complications, not clearly superior in terms of safety overall.
So why use them?
Often comes down to patient comfort, getting them up and walking sooner, efficiency for staff, especially with those large sheaths where manual compression is really tough. It's a balance.
The source describes different VCD types. First, extravascular plugs sealing from the outside.
Right. These deploy some material outside the artery at the puncture site. AngioSeal is a common one. Uses a tiny anchor inside the artery, connected by sutures to a collagen sponge outside. Sandwiches the hole. Dissolves in 60-90 days. Yeah, used for 5 to 8 French sheaths. ExciSeal uses a polyglycolic acid plug, also outside, dissolves in 60-90 days. For large bore access, 1225 French, the Manta device uses a resorbable collagen anchor sandwich. Initial data shows good hemostasis, but some complications reported. HH uses a plug from porcine submucosa, remodels into the wall. Minx uses a polyethylene glycol sealant outside with a temporary balloon inside during deployment. Sealant absorbs in 30 days. Reported low complications.
What about suture-based devices? Sound more like surgical closure.
That's the idea. ProGlide and ProStar XL aim to mechanically close the hole with sutures. ProGlide deploys sutures on either side, tied externally, mimics a surgical stitch. Big advantage. Theoretically, no limit on reaccessing the site later or on anticoagulation. Used for 521 French holes, often multiple devices for 8 Hayfart, are very common in Evertavia using the per-close pre-closure technique.
And ProStar XL, specifically for large bore, 8.5-10 French. Uses polyester sutures deployed by nitinol needles. Also maintains wire access during deployment, used for Evertavia. One trial, Bravo 3 in TAVR, suggested ProGlide might have fewer vascular complications than ProStar XL. So suture devices offer robust closure, especially for big holes.
Okay, that covers the closure devices. Now, the final section of the source gets into the how-to of the procedures themselves, starting with PTA technique. Accessing the vessel and getting to the lesion sounds basic, but critical.
Absolutely fundamental. Safe, effective access impacts everything. Where you puncture depends on where the blockage is. Common femoral artery, CFA, in the groin is most common for legs.
Things to watch out for.
Where the CFA splits can vary. Heavy calcification makes puncture risky. Might need to use the other leg's CFA, or even arm arteries like brachial radial or the SFA itself sometimes. Local anesthetic, always.
Guidance. Ultrasound can be invaluable, especially for tricky anatomy or antegrade punctures going down the leg. Helps pinpoint the artery. For below-the-knee work, ipsilateral antegrade CFA access is often preferred. Shorter path, better device performance.
Other approaches.
Bidirectional from above and below via popliteal for tough SFA-BTK CTOs. For gut arteries like celiac SMA, often coming down from the arm, brachial radial, works better because of the angle they come off the aorta.
Okay, access achieved. Next is getting the wire across the blockage. Principles, techniques.
Core principle. Get the wire through the true lumen, the original channel. Techniques vary hugely based on the lesion location, severity, CTO, plaque type. Thin wires, 0.0140, 0.018 inch, often used for tight spots or CTOs. Support microcatheters, help steer and support the wire.
Staying in the true lumen is key.
Ideally, yes. Sometimes use intraluminal crossing devices or IVUS guidance. If the wire goes subintimal, then you need those re-entry devices to get back in. Once crossed, confirm position back bleeding, small contrast puff. If antegrade downstream fails, might try retrograde upstream.
The source details different crossing techniques, antegrade, double wire, subintimal, retrograde, cart. Can you walk us through those?
Sure. Antegrade is the standard approach, access upstream, work downstream. Ipsilateral antegrade femoral for legs often gives best performance. For CTOs, use various wire techniques, sliding, drilling, rotating the wire, penetration, using a stiffer wire to puncture the cap. Wires like Gladius or Wizard PV for softer stuff, maybe Stato XS for hard caps.
Double wire technique.
Useful at bifurcations or if plaque might shift and block a side branch. Example, keep a wire safe in the deep femoral artery while working on the superficial femoral artery non-touch isolation. Kissing balloons at bifurcations use 2 wires too.
Subintimal angioplasty. Going around the blockage in the wall.
Exactly. Intentionally create a channel in the subintimal space.
B.
First described by Bolia. Use a hydrophilic wire loop, advance with a catheter, bypass the occlusion, then try to re-enter the true lumen distally. Often works, success around 80%, good limb salvage. Failure is usually inability to re-enter, hence re-entry devices.
Retrograde techniques coming from below.
Usually tried after antegrade fails. Access distal to the blockage, work backwards. Pedal access in the foot is common now for critical limb ischemia. Increases success but needs care regarding wound healing. Success rates around 85%. Can even go via collaterals, transcollateral, or the pedal arch, transpedal arch in complex cases.
And CART, controlled antegrade and retrograde tracking.
That's a bailout. If you can't re-enter subintimally, get wires into the subintimal space from both directions, advance till they meet. Inflate balloons next to each other to break the membrane between the tracks, allowing the antegrade wire to pass into the distal true lumen. Then you can treat.
Wow, complex strategies. Okay, wires across. Now, balloon angioplasty itself. How do you choose the right balloon?
Based on reference vessel diameter, the healthy artery size next to the lesion and lesion length. Balloons come in huge range of diameters and lengths now, up to 30 centimeters long.
Sizing strategy.
Often stepwise. Start slightly undersized, see how it dilates, assess stiffness, then size up to match the reference vessel. Be cautious with calcium. Don't want to rupture it. Accurate measurement is key use, angiography, CT, IVUS, sizing catheters. Balloon shaft length depends on access site and target location. Table 63.2 in the source lists sizes.
Placing the balloon accurately.
Use contrast puffs to see the lesion clearly. If it's hard to pass, might need a stiffer wire, bring the sheath closer for support, or switch to a lower profile, more pushable balloon. Center the tightest spot on the balloon.
Inflation time and pressure.
Prepare the balloon first flush air, fill with dilute contrast for visibility. Center the stenosis. Avoid overinflating past reference diameter. Longer inflations, maybe 180 seconds versus 30, might improve results. Reduce dissection bailout stenting based on Zorger's study. Inflate, deflate, maybe repeat. Don't pull back into sheath immediately. Severe pain could mean rupture. Keep wire position.
Vessel preparation comes up again. Why prep before ballooning or stenting?
Good prep minimizes dissection risk, maximizes lumen gain, and sets the stage for implants like stents or DCBs to work optimally. Crucial for calcium. Can involve predilation with undersized balloon, using scoring cutting balloons or atherectomy.
Especially needed before DCBs.
Often, yes, to ensure good drug transfer. Atherectomy debulks plaque. Definitive AIR trial suggested atherectomy plus DCB might be better than DCB alone in long calcified lesions if prep is effective. Superb trial with Super stent also stressed optimal prep for good deployment.
Finally, dissection grading after PTA. Why classify the tiers?
Dissection is common after ballooning. Grading A to F based on angiographic look flap, staining, flow limitation, occlusion helps decide treatment. Minor ones, A, B, might be okay. Major ones, CF, usually need stenting to tack the flap down and restore flow. Crucial for deciding next steps.
Okay, that covers PTA technique thoroughly. Let's talk stenting technique. When is stenting indicated?
Indications vary. Iliac lesions, especially complex, TAS, CD, primary stenting often yields better long-term results than just ballooning with selective stenting. Elsewhere, selective provisional stenting is common use as a bailout for PTA problems.
Of what problems?
Flow-limiting dissection, significant residual stenosis, 30% left, a pressure gradient, 10 mmHg Hg across the lesion after ballooning, or acute occlusion right after PTA. If a dissection extends into healthy vessel, that needs stenting too. For extensive stenosis, options include cutting balloons, atherectomy, repeat stenting, maybe DES are covered, but evidence isn't always clear-cut. Using stents in no-stent zones, CFA, popliteal, BTK is controversial, often needs surgical backup.
And stent fracture, we touched on it. Why does it happen?
More common in long stents, 80 millimeters overlaps, and areas with lots of bending, twisting, compression like the popliteal artery. Stiffer stents might fracture more easily in the SFA. Can lead to restenosis, sometimes significant, sometimes not. There's a classification, type 0Y, based on severity. Choice of stent and location matter.
Choosing between BES and SCS. Key factors again.
As we discussed, Table 63.3, BES are great for short, focal, calcified lesions needing precise placement and high radial force. Osteolutions, too. Kissing stents at iliac bifurcation use BES. SES are better for long, tortuous lesions, areas prone to compression, external iliac, SFA, internal carotid, post-stent graft dissections. Flexibility and kink resistance are key advantages there. Consider forces, anatomy, precision versus flexibility needs.
Technique for implanting a balloon expandable stent.
Size at 5–10% larger than the reference vessel. Predilate the lesion well to avoid stent dislodging. Get wire across, confirm position, mark lesion. Advanced balloon-mounted stent, confirm position with contrast. Withdraw sheath. Inflate balloon under fluoro. Watch for even expansion. Doggy bone, normal initially. Ensure no dislodgement. IVUS helps confirm apposition. Keep wire position. Can post-dilate BES further.
And implanting a self-expanding stent. Differences.
Key differences. SES are flexible, good for long lesions. Size 1 to 2 mm larger than reference vessel. Can't expand beyond stated size. Predilate lesion. SES is in a covering sheath. Less dislodgement risk during delivery. Deploy by slowly retracting the covering sheath under fluoro. Watch for the jump forward. Most aren't repositionable, except wall stent. Must post-dilate SES with a balloon after deployment to ensure full expansion and apposition.
What about the Viabon endograft in the SFA?
It's a self-expanding covered stent, indicated for long SFA lesions. Viastar showed better results than bare metal stents, even for very long, 20-centimeter lesions. Can be an alternative to bypass surgery for high-risk patients with complex SFA disease.
Well, this has been an incredibly thorough deep dive into endovascular therapeutic techniques. We've covered a massive amount of detail.
We really have, from basic balloons to complex stents, atherectomy, thrombectomy, CTOs, closure devices, and all the technical nuances. It's a lot.
It's clear that endovascular therapy is just a hugely sophisticated and rapidly evolving field. So many tools, so many techniques for different vascular problems.
And understanding the specifics of each device, when and how to use it, is absolutely critical for getting the best patient outcomes and avoiding complications in peripheral artery disease.
It's also just amazing to see the constant innovation, things like drug-coated balloons, the ongoing work on bioabsorbable stents. It really points towards even more advanced treatments coming down the line.
Which brings us to a final thought for you, our listener. With all this constant innovation, how might the whole landscape of treating vascular disease look in, say, the next decade?
Yeah, what new possibilities and maybe what new challenges will these advancements bring?
Exactly. It's always that balance, isn't it, between pushing forward with technology and ensuring long-term patient well-being and safety. Something to ponder.
A really thought-provoking question. Thank you for joining us on this deep dive. We hope this gave you a valuable and efficient path to understanding the core elements of endovascular therapeutic techniques.
Until next time.